Hi, this is Professor Luchin. This is a lecture 11. I typically cover bloodborne pathogens and the sanitation standards, first aid standards, things like that later in the semester. But due to the pandemic, the global pandemic we're going through, I decided to bring this up as being the first applied topic for the summer 2020 class. This particular PowerPoint slides or presentation was created through the University of Arlington. You see it right here. University of Texas at Arlington. So they're an OSHA educational institute, and so they provide these slide decks for training purposes. So I'm going to borrow it from just so I can hit the basics. Now, this was originally created for healthcare settings. That's where you're primarily going to find bloodborne pathogens, but viruses fall under this subject header. So I'm going, but now, yeah, sure, they're we're talking bloodborne stuff here, but again, if we're going to talk about pathogens, which can be in other forms other than blood, so we're starting here, and then we're going to expand to the COVID. So this presentation is primarily about hepatitis B, which is a bloodborne disease, and the HIV. So the standard that I'd want you to take a look at is 29 CFR 1910 1030. And interesting, it was effective or published, in 91, 92. I know when I was a compliance officer in Minnesota, we received the packet from them that kind of detailed information about the standard, letters of interpretation, and stuff like that. And on the front was the biohazard symbol. And actually, I took that into a tattoo artist, and I've got the bloodborne pathogen symbol right here. So that was my first tattoo. And then so the guy's like, a tattoo artist like, I've seen that before. Where have I seen that? I'm like, right over there on your Sharps container. He's like, oh, that's cool. Can I take a picture? And then everybody got it. So the big thing is, and I'm just going to come out with what I wanted you to take out of this, is that you can't tell by looking at it, smelling it. I don't want to say tasting it, but you can't tell if blood has a viral agent, a pathogen such as hepatitis B or HIV in it. It has to be tested. Bodily fluids that may have trace amounts of blood in it could also be infected with these viruses. So what they do is they treat it they practice something called universal precautions, and that's what I wanted to talk about. Universal precautions assumes all blood and bodily fluid is infected with a virus. You maybe don't know what it is, but by treating it as infected, you're protecting yourself from becoming infected by it. And that's what they do in a lot of hospitals. So if you can reasonably anticipate that it could either be, there are different entry points for blood contamination. So there's a lot of different job titles within a healthcare organization that may come into contact with these things. So the employer is supposed to determine the exposure for everybody on site. Now, does that carry over for infectious disease, such as the COVID-19? Yeah, it does. So at the university, their committee should be doing exposure determinations, and then based on those exposures, determine what is the best course of controls or mitigating strategies that reduce the likelihood of an infection. So exposure control plan, basically methods for compliance. If there's a vaccine, how is it going to be given? Or how are you going to test for if there is an exposure, or is there a prophylaxis? Which is something you do so that if you were to be exposed, you're not going to be infected. And then there is the record keeping and communication. So it talks about procedures. That's basically what it is. All routes of entry. So we're going to talk about COVID in a little bit. Bloodborne, it has to come from an infected patient or a patient. Sometimes they're doing blood draws. Sometimes they're delivering, vaccines or shots. That's not probably what they're using, some sort of syringe to puncture the skin. The patient may also be vomiting or have an open wound and be bleeding or be coughing up bodily fluids, or maybe bodily fluids are on their person when you're trying to treat an emergency. And so there's a lot of different ways. So, keeping hands covered or protected, having your body covered with something, a face shield, a splash guard, something for the eyes, are all meant to protect routes of entry. And then we bring up universal precautions or standard precautions. Because they're all contact with blood or potential infectious materials, all bodily fluids are considered potentially infectious. That's the best way to do it. But I mean, it may seem simple, but it comes with its own set of issues and barriers, such as they're not supposed to be able to brew coffee at a nursing station because of universal precautions. Because if somebody gets bodily fluid on their gloves, they may take them off, or it gets on. They can't just go back and go grab a cup of coffee, and so that has to be a designated place, a kind of like a decontaminated place where they can decontaminate before they enter it. So there's like a decontamination zone, and then they get into a break room or whatever it is. They've cleaned off or derobed or whatever it is. Now they can consume food and, in sort of a sterile environment. And then when they go back out to work, they put on new sets of coverings and go meet with patients. But they should, take that off and wash down, decontaminate, or sterilize before they go back into an area where they're going to consume food, drink, or possibly, take off whatever they have on. So there are different forms of engineering controls. As you read this, it's coming back. One thing I do whenever I do inspections of healthcare facilities is if they have a refrigerator that contains samples or medications, I always look in it to make sure nobody has put any food into it. And I'd say 90% of the time you find food items. Gross, especially right next to the urine sample. Is that vinaigrette? No, it's urine. Practicing good hygiene, hand hygiene. So when they're washing their hands, it's not just a squirt wash. I mean, they actually scrub down and make sure each surface gets ample amount of scrubbing and soap, and then completely rinse it. Make sure you dry clean as well. Washing your hands is not using a hand sanitizer does not replace or is not as effective as actual hand washing. But, when you have to, when you don't have any other option, that's one way to do it. If you have gloves, you have to know how to properly remove the gloves. So as you take it off, you leave the contaminated surface on the inside as you pull it off, and then you do it over here, and now they can be disposed of. They may have to be disposed in a biohazardous container, but you turn it inside out so that anything that has touched another surface or another person or another person's bodily fluids, it's on the inside of the glove. So it's okay to touch what is now the outside, which used to be the inside. Turn it inside out. I should have just said that. I talked about PPE before. It all is provided by the employer at no cost to the employee, and includes all these things. And this comes with training. Workers need to know how to put it on, take it off, inspect it, how to store it, how to clean it, all these different things. Yeah, same thing. For housekeeping, environmental services, they need to realize that even though they're not getting direct exposure with patients, they're there to clean up the environment, so the room afterwards. So basically they have to treat as if every surface is contaminated and make sure they protect themselves and are able to sanitize as required. Sharps are another big issue. They've been a big issue because if you once you inject a needle into someone's person, that is now a contaminated item. And the thing is, once it's removed, if you just nick yourself, that's called a needle stick. Whatever was on that needle has been injected into your bloodstream. Waste needs to be handled differently when it's biohazardous. A lot of it is pretty easy, but like things like gauze and Band-Aids, what they say is if you squeeze it and it forms a droplet of bodily fluid or blood, that is considered biohazardous waste and needs to go in a special regulated and marked bag for special types of disposal. But if any blood or bodily fluids in a bandage or a gauze cannot be squeezed into a droplet, so it's completely encased or dried into it, then it can be disposed of in regular garbage. It talks a little bit about contaminated sharps. You guys have probably seen those sharps containers in any sort of public bathrooms. They've got the biohazard symbol. It also has the top where you can't reach into it. You dispense your spent sharps and then you turn it and it drops it into the container. And those things need to be checked and replaced. They're never supposed to get full. Yeah, sharps are a big issue in healthcare. So if you ever have to work for a healthcare organization doing safety and health, there's a lot of great information on the OSHA website, and I've provided you with a lot of resources, links, and PDFs, which cover the wide range of bloodborne pathogen hazards or just overall health hazards that you'd find in a healthcare organization. The two primary viruses are the HIV and the hepatitis B, so that's what they talk about the most. But there may be a new one, as soon as next year or the next week. Who knows? Use labels and signs and information. Again, employees should be trained, but then as a backup, as a reminder, you provide signs and education. There's more information on it there. You need to keep medical records. If somebody is, but here's the thing. This is where things kind of cross over with HIPAA, which is privacy of health information. So if somebody experiences a needle stick or an exposure to a blood or bodily fluid, and this probably and I bet you exposure to COVID falls into this area as well, any records do not have to have your name on it. Your name can be redacted because that is a personal thing. A record of exposure or a positive test needs to be kept, but the name of the person is kept anonymous. And the record keeping standard does talk about that. Why do we not have enhancement compliance? Lack of training. That's a typical one, because you can't follow all the administrative things because we're busy and rushing. Decreased awareness of hazards. I guess if you become complacent, if nobody's had a needle stick for a while or an exposure for a while, or just the overall thought that it won't happen to me, you got to be constantly reminding people. All right, so we got through that. So here is what I've posted under Lecture 11. So here's the PowerPoint we just went through. Here's a link to OSHA's needle stick prevention and bloodborne pathogen, their healthcare-wide hazards e-tool. It's pretty cool. Their fact sheet, Red Cross's fact sheet. And now what I'd like to do is get into the COVID. First, I want you to see I've been working on my background, trying to get my office all set up. I'm kind of excited to start using it to its potential. But before we move into COVID, I want to just let you all know that there are also foodborne illnesses that you need to be aware of. And so I did a quick search. I looked up E. coli, and these are all under the Mayo Clinic. This is stuff that's interesting. If once in a while we hear on the news, there's been a recall on romaine lettuce or spinach because of E. coli. And I don't know if you've ever thought, where does that come from? E. coli is something that is found in the digestive tracts of animals, typically cows. And the way it gets into our food is because remnants of fecal waste get into our food or into the water that is used to grow food. So if there's E. coli in meat, there's fecal matter in meat. Now you can kill E. coli through heat. But when it's a when you consume something raw, such as spinach or lettuce, it doesn't receive that heat. So any E. coli bacterium, it's a bacteria, in there is going to be consumed. And there's a newer strain of E. coli. I don't know if you can see it on the screen. It's O157H7. It adopted some resistance characteristics from a virus, and it attacks both liver and it can attack kidneys, and it can be actually deadly in the young, the old, and the infirm. Kind of scary, because it just used to be, you get some diarrhea, not so much anymore. Now it can actually hurt you. And one of the things is this hemolytic uremic syndrome, or HUS, and this is where it can damage and shut down the kidneys and kill you. There's also antibiotic resistant bacterium. This one is called MRSA. It's a scary thing. We don't have any antibiotics to fight it. It eats away at flesh until maybe something works or the body finds a way to fight it off. But we have things that we have bacterium that we don't have antibiotics to fight. Less common is this viral hemorrhagic fevers. This is bleeding. Watch the news every once in a while. They happen in South America, and sometimes it gets into our news cycle. But these things are scary because it liquefies internal organs, or there's bleeding under the skin. Kind of gross. And I was looking more about the E. coli, then also hepatitis A. This is a foodborne illness. Typically comes from very poor hygiene of people who are handling or preparing food. So, having covered all that, you guys are pretty excited, I'm sure, about all that. Hopefully you're not eating right now. Let's get into the COVID. I put together a short presentation based on Dane County stats. I want to talk about that. There are all kinds of links here, and the reason I wanted to bring this up is because I've been put on a committee for returning to campus, and so in the last week I've been hyper studying this stuff so I have a better idea. And interestingly enough, my recommendation, which is actually going to be shared tomorrow, the 20th, is I'm recommending universal precautions for all faculty and staff, because the SARS-CoV-2, which causes COVID-19, is so sinister in that it infects, and the host can be a spreader to other people without them knowing, and it's so resilient in how it's able to get into the body and replicate itself faster than most individuals or human biology can fight it off. The immune system can react. Which is why we need a vaccine. Now, I did find a video. It's 7 minutes 30 seconds long on YouTube that goes into the mechanisms of infection and what a vaccine does. And I think it's very educational. So please watch it. I think you'll get a lot out of it. My daughter was watching it over my shoulder when I was reviewing options, and she even understood it. She's 10 years old. So please. So let's check out what I had found with Dane County. And forgive me, I always have to switch screens here. And so this is data that's available online, but I tried to make it a little bit easier to consume. Oops, sorry everybody. So here is what the Dane County dashboard looks like. And I've been monitoring it since mid-March. Every county should have something like this, but it varies depending on. So what we have on the big screen here is the cumulative case number. And I mean, you guys are smart, so you can see how when things are kind of like level like this, but then when they shoot up like that, the question is why. They've got the number of confirmed cases in Dane County is just under 3,500. The total tests are here. The total people tested are much lower than that. There were 261 people ever hospitalized. That's gone up a little bit lately. And the deaths it's gotten up to 30. Now it's only at 33, or like for the last month or something. So why, people, they say, oh, well, it's not as deadly. Well, no, our doctors are smarter now. They know better how to treat it. And so less people are dying. So therefore, let's start talking about some of the comorbidity outcomes that people are experiencing. And I'm reading more about that, and it can affect their lung function. It may permanently damage it. People are talking about nerve damage, kidney damage, liver damage, never being able to really, feeling like they're constantly fatigued. I've also heard depression is another symptom or outcome of it. So this is the overall chart. So what I did is I took the chart and I what do they call it? superplanted. No, that's not the term. Anyway, I put some information on here, and what I aligned it with is what the numbers were based on some key indicators. So I went back to April 13th when there was only 346 positive cases. So 2 weeks later, which would be April 27th, it had gone up to 420. That's a 21% increase over 2 weeks. Okay, I'm building a baseline here. 2 weeks later, it's gone up to 480. That's another 14% increased over 2 weeks. On the 26th, there were a total of 660, which is just a 37.5 increase over a little over a week's time. So you could see, therefore, a 6-week span starting back in April 13th. There seemed to be, a 21, a 14, a 37. So the increase every 2 weeks varied from like a low 15 up to a high of 40. So then on May 26th, Dane County moved to phase 1, in which businesses were reopened at a 25% capacity. They're just asking for distancing and other things, but there were still a few other things that remained closed, such as gyms. And I'm not sure, I'm pretty sure the bars had opened at a small capacity at that point. On June 15, Dane County moved to phase 2. Businesses went to 50%. Now a lot of things could open at that point. As you can see, the number of positive cases on the 15th is 981. This is an 185% increase over 19 days, so about 2.5 weeks. So that's a greater increase than what we had in that first 6 weeks, which I'm kind of considering the baseline. That's when we were kind of staying at home. On the 29th, which is 2 weeks from the 15th, the total positive cases had jumped to 1,879. This is a 91.5% increase over 2 weeks. So over twice what it was during our baseline. And the thing is, the things that went on between the 15th and the 29th were likely a result of the behaviors and changes made from the 26th to the 15th, because there's such a delay. There's the exposure, and then there is sort of the incubation period, and then there is I think I have symptoms, and that's like in a 7 to 14 day period, and then you go get tested, and it's like another 5 days. So you're talking like the behaviors that are exhibited may not result in knowing that you were infected from them for anywhere from 14 to 21 days. And so you got to think of it that way. That what were people doing, and then 14 to 21 days later, you're going to see the result of those choices. On the 13th of July, we're getting up to closer to where we are now. We're now at the 3,149. This is a 67% increase over 2 weeks, and this likely has to do with the behaviors exhibited between June 15th and June 29th. So we're not really seeing the result of 4th of July just yet. As you can see here, from April 13th to June 15th, over 2 months, we saw an increase of 635 cases, which is a 183% increase. But from June 15th to July 13th, which is just under a month, we had a 221% increase. So the numbers are going up. And why? Because we went from phase 1 to phase 2 very quickly, and the behaviors that were being exhibited resulted in more positive cases. But let's look even further into the data. And you can see here, based on my arrows and what I put in here, some of the things we were seeing. So then I've got two here. I've got one with new cases with 7-day average on the top, and the bottom I've got the percent tests that were positive by date. So what you may be saying, and rightfully so, that the more tests you have, the more positive potential you have. That is true. But another question is, if you have an increase in tests, are there more people that feel ill? Well, then you got to go to the percent positive, because the more people that you test, the less percent you should have, because you're increasing the total. But what we're seeing here on the bottom is that right now we're at the highest 7-day average, and as late as 7/14, 4 days ago, we had a day in which we had almost 29% positive. That's kind of scary. So even though, and the tests, these numbers change over like a 3 or 4 day period as they roll in and numbers are finalized. But all these indications are that perhaps the movement to a phase was too quick, or people didn't heed the distancing and masks, and so the numbers are going up. And so here we're seeing a chart of the people who are hospitalized and the people who are in the ICU. So, as very recently, we're up to around a 33 inpatients. We're not taxing our capacity for inpatients, but the number, after experiencing a low in early May, and so you got to think of what we're doing in sort of early mid-April to get there. We're not doing that. Numbers are going up, and that's concerning. And then we look at the ICU patients. That tends to be an older population. So that has been, kind of bouncing around, typically around 9 or 10. So I took these numbers out so we could talk about them. So the total estimated population of Dane County, based on July 2019 census information, is just under 550,000. The total number of people have tested as of today is about 92,000, which is about just under 17% have been tested, some of them multiple times. The total tests have been just under 3,500. So from a population perspective, under 0.6% have been positive. So that seems like a very small number. But when you look at the percent positive tests as total, it's about 3.8. But the thing is, it's 3.8 because irregardless of the higher numbers we've had recently. So that even more kind of shows an upward trajectory. At the bottom, I've got it broken down by age group. So I've got the confirmed or positive tests. I've got who got hospitalized, and then who, by age, are the mortalities. And as you can see from the screen here, the age group of 20 to 29 accounts for almost 42% of all positive tests, yet only 1.8% of inpatient and no deaths. So that's a big number. Then if we go to, let's say, people over 60, they're under 6% of the total positive. They're 25% of the inpatient and 2.4% of the mortality. If we go up to the 80-year-olds, 80 to 90, they're only 1.6% of the total positive tests, but they are 56% of those hospitalized. No, I'm sorry. No. This is 56% of the confirms. So they're only 1.63% of the total, but of the 57, 56% of them get hospitalized, and about 17.5 of them die. If you're over 90, you've got to basically two-thirds chance you're going to be hospitalized and die. So age seems to be a very dependent variable on whether the case is so severe, or the disease is so severe that you have to be hospitalized, and ultimately you can see the older you are, if you're over 60, the risk is there. It's very evident based on the data there. So that's all I really wanted to cover. I'd like you to watch the video that I had posted for how SARS enters the body. SARS-CoV-2 is the name of the virus. COVID-19 is the disease. And then maybe take a look at some of this other information. I could also share, I had a student who's out interning right now that I'm supervising. He tested positive, and he wrote up a report about what he experienced, and it gave me some great insight to what it's like, which is why I feel very confident that a universal precautions needs to be adopted if we're to reopen campus. So I hope I get to talk to all of you this week. This will be one of the topics we discuss, but please reach out to me if you have any questions or concerns.